Bonnie is an MSW, an RN, and an ATAF. She is also a Matrix consultative partner and a Matrix advisory board member. She is the owner and manager of Reconnect for Health. She has been a remote monitoring early innovator and an advocate. And Bonnie clearly injects her education that she provides for us today and with others with enthusiasm and Southern hospitality. It's all yours, Bonnie.
Thank you so much, Anita. Hello, good afternoon, everyone. I'm glad to be here to talk with you about remote patient monitoring and chronic care management. Remote patient monitoring is my passion, and it has been for the last 20 years of my career. So thank you for attending, and please, if you have any questions, if you'll send those to the Q&A, then at the end of the presentation, we'll take those questions, and I do welcome them. So today, really what I want to do is to help you understand the journey of chronically ill patients, and we're going to do that through talking about Mr. Doe's Wild Ride. And then we're going to examine remote patient monitoring, applications, implications, as well as outcomes, and talk about the true benefit of remote patient monitoring depending upon the location that you are providing that service, because it does vary. And then I want to help you gain knowledge on ways to increase your Medicare revenue. If you're a primary care provider practice, if you're a health system that owns primary care practices, there's a real opportunity now to increase revenue and increase care coordination as well. So having done that, we're going to talk about Mr. Doe's Wild Ride. And let me tell you a little bit about Mr. Doe. He is a 78-year-old male. He has a history of hypertension and diabetes. He lives with his wife, elderly wife. They live alone. Their grown children are scattered across the country, so really don't have a lot of support locally. They live in a very rural area. And Mr. Doe, he wakes up one morning. He's not feeling really good. He's tired, a little bit short of breath, but nothing, that he thinks is unusual. And so he goes to his primary care provider at location number 2. That provider does an assessment, as they always do. They draw labs, they order x-rays, they send you home to go back and then to come back into the practice in a week from now to give the results of your lab. So Mr. Jones goes to the clinic, goes back home, goes back to the primary care provider clinic in a week, and at that time they tell him that they would like for him to have a cardiology appointment. It's going to be 2 weeks away at the Academic Medical Center, which is about 60 miles from his home. And so he accepts that he will do that, and he goes home at location number 5. On the day that he's supposed to go see the cardiologist at location number 6, he's really feeling better. He doesn't have a lot of money for gas. His truck is kind of old, and he just decides that, you know what, I'm feeling okay. I'm not going to go to that appointment. Happens all the time, doesn't it? So he stays home. And while he's at home, he has a medical event. He's not sure if it's a stroke or a heart attack. He falls down the steps, and 911 is called. 911 then transports that patient to the regional hospital. So now you've incurred the cost of an ambulance ride. Now that patient is in an emergency department in a rural area that doesn't have cardiologists and doesn't have neurologists, and they don't have telemedicine. So the only option for this patient is to be airlifted from the rural area to the tertiary care center's ED at position 11. I hope if I could see everybody, I would hope you'd be seeing nodded heads, because this happens all the time. The patient comes into the ED, then they have tests done that were replicated tests from the tests that were done at the local ED. Then they're taken to intensive care unit at location. Then they're taken from intensive care to an immediate care level. Finally, they go to a regular hospital bed, and it's the day of discharge. And what happens? Does the patient hear or understand anything that's being said to them at discharge? No. They're thinking about going home. So the patient goes home at location 15, and the cycle starts all over again. And so today, what I hope we can demonstrate to you is there are several ways along this wild ride that you can interject remote patient monitoring and break this cycle. One of the locations you can do that is the very first, when the patient came back at location number 4, and the physician says you need a cardiology appointment, and we're going to order remote patient monitoring. So that patient would have taken home a blood pressure, pulse, scale, pulse oximetry if needed. He's diabetic, so he could monitor his glucose. And that way, every day, in between the time he was at the physician appointment to the time the cardiologist, a registered nurse could see that data, and if anything was occurring, they could notify that. So by intervening at that level, you can potentially prevent the rest of the ride. An example of that is I worked for a large federally qualified health center in North Carolina, and we established the first patient-provider telehealth network, where primary care providers were identifying patients who potentially were at risk for their illness progressing negatively, as well as folks who lived in rural areas or experiencing poverty, health literacy issues, etc. And we were able to demonstrate with this model that we had statistically significant reduction in hospitalizations and healthcare costs, and that was validated by Wake Forest University, excuse me. And so we were able to decrease hospitalizations by 78%. And this was a network that was established with 7 primary care providers or federally qualified health centers across the country. The other location that you can make a difference is at location number 14. That is when the patient is being discharged from the hospital. The hospitals and health systems are implementing post-discharge remote patient monitoring programs to prevent this entire cycle. And you'll see some outcomes and descriptions of that later on into this program. So there's a lot of different areas and ways that you can use remote patient monitoring to benefit and the patient as well as to decrease costs. And this is just another example. If this had started at location number 2, which was that first primary care provider visit where the patient was complaining, then you could really have stopped that entire process. So remote patient monitoring, there's lots of definitions. Basically, it's secure collection and transmission of patients' biometric data based on their diagnosis. So if it was a diabetic, they'd have a glucometer. A patient with cardiovascular disease would have a scale, blood pressure cuff, etc. Someone with COPD would have pulse oximeter. You could have Fitbit data. You could have heart rate monitor bands that go around the arm. There's lots and lots of gadgets and biometric data available. And then it's the combination of obtaining subjective data from the patient outside of a clinical setting. So historically, I've been doing this for 20 years this month, and historically the emphasis has always been placed on due diligence on the device vendors, and I believe that that is an important component and one of the 3 legs, the legs of the remote patient monitoring stool. But so much attention historically was placed on that. There was not a lot of attention focused on clinical workflows, infrastructure. How do you gain support for the program? Do you have a champion? And do you have registered nurses monitoring this data? So when a patient collects their data on a daily basis, that data is transmitted, encrypted and transmitted to a secure cloud, and then we'll talk about later modes of transmission. And then that RN is going to review the data. Anyone that has abnormal data, they call the patient, they conduct data validation, meaning is that your blood pressure? Did you take your medications before you took your blood pressure? Did you sit in your chair for 10 minutes and rest before your blood pressure? So it's really validating that the data that was received is accurate and actionable data. If it is valid data, then the nurse conducts a nursing assessment, provides education, they engage the patient, that to help the patient make the correlation between what they did and did not do yesterday and how they feel today. And then most importantly, that's escalated, the validated actionable data is escalated to that patient's primary care provider. This is the optimal conceptual model for remote patient monitoring because you are gathering, let me say it this way, data collection for data collection's sake is not very meaningful. But when you have objective data that's validated, you have subjective data from that patient, you apply nursing assessment just like a nurse at a bedside, engage and educate that patient, make that correlation, and then escalate to a primary care provider when a medical intervention may be needed. That's where you truly can start the breakdown of Mr. Doe's Wild Ride, because you intervene early from an assessment perspective and then intervene early from a primary care provider perspective. Anytime that I work with any remote patient monitoring program, and believe me, if you've seen one, you've seen one. They're all different because they're based on different goals. What I have learned over the past 20 years is I'm a clinician, so I never really thought about the financial end of things. But what I've learned in the past 20 years is it really doesn't matter if you do the best job in the world from a clinical perspective. If you can't demonstrate a financial ROI based on financial goals, the program's not going to scale. It's going to stay stuck and mired where it's at. So the very first thing that I recommend anyone to do is to meet with the chief financial officer or someone within that department to truly identify where are the financial gaps, barriers, issues that that organization is facing. And most CFOs are going to tell you, we know what those are. And most of them do. But sometimes you find things that you weren't looking for. For an example, I was working with a large academic medical center, and they were convinced the area that they needed to work on were Medicare, less than 30-day readmission. And so we had them pull all the financial data on Medicare as well as self-pay patients, and there was another category for chronic conditions. And what they found is that with their example, heart failure, less than 30-day readmission, they were only losing about $800 an admission, which is not good. But for the patients that were self-pay, they were losing a little under $9,000 per hospitalization. And we say, well, how can there be so many patients that are self-pay with Obamacare? People are still paying self-pay, as well as you've got a whole set of patients now who are in the Affordable Care Act, and their premiums are so high that it's going to take them years to pay that off. For an example, I fell 9 weeks ago today. My friend drove me to the emergency room, so I didn't have that expense. I was in the emergency room. I had a CT scan, an X-ray of my wrist. I was in and out of there with a plastic surgeon doing 50 stitches. The bill thus far is over $9,000 because my insurance premiums are at that limit. So for anyone, it's going to take a long time to pay that debt off to the hospital. And so there's lots of different ways to look from a financial perspective. And I give you those examples because I want you to think outside of traditional less than 30-day readmission. That's critical if you're working with an organization who is paying the max penalty. But if you're trying to do that for an organization that's not paying max penalties, you can't create a return on investment. Now, the other things you might want to look at are decrease in inpatient admissions, which right now is a really slippery slope because we're still under DRGs and payment structure, and everything hadn't shifted yet. So CFOs are quick to say, I want the inpatient admissions, because we generate revenue. So that's the same with ED visits. Again, it's looking at what patient populations are struggling with paying their bills and being able to pay us back. What contracts do we have that we can implement programs to decrease that contractual loss, and how can we decrease overall healthcare expenditures? Then you need to determine your clinical goals. Is it an increased access to care issue if you're working in a rural area and federally qualified health centers who have high health illiteracy and a lot of poverty? How do you get access to these patients if they can't drive or they can't go to the next town? Are a certain patient population having issues with their clinical outcomes? Are you struggling with patient satisfaction scores, positive patient satisfaction scores? Do you need to increase your quality scores, especially in light if you're working in primary care with the new initiatives of macro coming? And then how can you expand remote patient monitoring from a population health perspective? So we'll talk a little bit about devices. Everybody has devices, and that's great. They're all FDA approved. So when I started 20 years ago, it was really important to focus more on technology. But now there's so many companies with gadgets, and most of them, all the gadgets are really good. So here's just a sampling, not from any particular company, of different devices. So first are scales. Patients weigh right after waking and voiding. Depending on your patient population, you may need to have those scales to go up to 500, to weigh up to 500 pounds. I recommend scales that you don't have to press a button or do anything, just step on. And then there's a voice that lets them know what that weight is and step off. Making it easy for the patient, especially elderly folks who are trying to stabilize on a scale. And I like to have a wide base scale for those frail patients and also patients who are obese. A blood pressure pulse meter, we recommend they take their blood pressure an hour after taking their medications and after resting in their chair at least 10 to 15 minutes. Of all the devices, the one that you have to validate the most for accuracy is blood pressure, because if they cross their legs or if they bend their arm, there's so many user errors that can occur with the blood pressure. This is where you usually have to spend, if you do have to spend time validating, this really is the one that you'll focus on. Pulse oximeter, patient simply puts their finger in the pulse ox and it gives them their oxygen reading. Glucose readings as ordered. Again, some companies manufacture their own devices. Other companies manufacture enablers that connect to the patient's devices. So when looking at your diabetic patient population, you really want to have a good understanding of what meters current patients are currently using and making your decision. Then now there's medication reminders. This little device you program into a free app on your phone, and it vibrates like a Fitbit. It vibrates to let you know it's time to take your medication, and a color light comes on, and that same color is on the top of the pill bottle the patient's supposed to take. So that's an example of a very inexpensive way to help folks who forget to take their meds to take their meds. And here's another example of a medication dispenser. And this device, I would have given anything to have it before my mama passed, because she took a lot of medication. She passed away at 92, and I had to drive 120 miles round trip every week for 10 years to fill up her med tray. This device holds up to 15 meds for 90 days, and it's programmed through software. So there's lots of things now that can really help patients age and stay at home and help their caregivers as well. Telehealth platforms. When telehealth remote patient monitoring started, everything was using the plain old telephone system. And now we have cellular, we have Wi-Fi, they're using tablets to do transmission, smartphones with apps, and now smart TVs, and I have a picture of that for you in a little bit. So whatever mode of transmission, the key is understanding your geographic area. Let me give you an example. Working with Appalachian Regional Health in Appalachia, Kentucky, and a lot of their patients don't have landlines, plain old telephone system, or if they do, they're very, very old, so they're not reliable. Cellular connectivity is a huge challenge. Some patients have internet, others don't. So when they knew that they couldn't look for one solution to meet all of their needs, because if they picked a vendor that just had Wi-Fi, then that's the only way you can transmit. So to me, it doesn't matter which of these applications or which vendor you go with, as long as you understand your patient, with their phone lines, if they have phones, if they have internet, if they have cellular connectivity. Very, very important, because you don't want to make a commitment and then get in there and the issue's transmission. All of the platforms have encryption and cloud storage, and then all the vendors also have cloud-based software and data analytics that's built in. And what I want to say about the software, there's three legs of a stool of remote patient monitoring. One is the technology that we've just talked about. One is operations, and part of operations is having robust software to be able to replicate normal clinical workflows for remote monitoring, as well as what analytics, what reports are within that software. Do you have the information that is needed for me to be able to run reports and demonstrate returns on investment, or clinical outcomes as well. So here's an example of a device that transmits via POTS, internet, or cellular. And this is a new company that has just come out, and they have created a box. It looks like an old cable box for those of y'all my age, know what they look like. They connect it to the patient's television, and then all the data that is collected from the biometric sensors go onto the TV screen. So everybody has a television. Everybody has a TV. So this is, I think, really exciting that this may be coming to a TV, to a patient real soon, which again in the future is going to lower costs with transmitting devices. So that's some of the future. I wanted to tell you a little bit about, give you some outcomes. Before starting this company 3 years ago, I implemented the Britton Health Remote Patient Monitoring Program. Britton Health is a large academic medical center, tertiary care, that has a 1,000-bed medical center, and then 9 rural hospitals in a 29-county of eastern North Carolina. And we implemented a post-discharge, hospital discharge program to increase access to care because of how rural we are, lower admissions, lower bed days, enhanced communication between patients and providers, and engage the most high-risk, high-cost, low-engaged patients. So we identify patients with cardiovascular disease, pulmonary disease, diabetes. We administered a patient activation measurement tool on these patients to identify the patients who are the least engaged. And then we sent an LPN into the patient home to do a med reconciliation and comparison from the discharge instructions that came home. They did an assessment of the home, the refrigerator, the cabinets, to find out, does this patient, what did they use to cook with? What are their processed foods that they eat? And then those patients on a daily basis collected the following data. We had registered nurses who called those patients, validated data, conducted an assessment, education, coaching, everything I described earlier, identify the primary care provider, and then we did weekly assessments, education, and coaching for all patients, no matter if they had alert or not. And then we had provided biweekly data summary graphs to those patients' primary care physicians. When we started the program, the 3 months before telehealth, we had 683 patients year one who completed the program. 3 months before starting remote patient monitoring, 512 patients had 820 hospital admissions. The 30 months or 90 days during remote patient monitoring, 171 patients experienced 270 hospitalizations. So there was a significant reduction, 67% reduction in hospitalizations for this population. And this was overall 3 months. So it shows that it helps the patient stay out 3 months during it. And then we removed the device and we pulled data 3 months later. And as you can see, the number of patients and the number of readmissions continued to decrease. Bed days are very, very similar. And as you know, with reimbursement with Medicare, every bed day counts because if you can shorten those bed days, you get the same amount of reimbursement whether you're there a day or 4 days. And so, again, this was, and I wanted to note the reference for these slides, I could, for some reason, couldn't get it on the previous slide, is down here at the bottom. If you want to reference, it's a CAS report from 2013. And then this is the one I found very, very interesting. So we had a population of heart failure patients who, we had 35 patients met all criteria for the program, but refused the program. We had 52 patients who met all criteria with heart failure and completed the program. So we compared these two groups of patients. The 35 patients who qualified but refused, their less than 30-day readmission rate was 28%. For those 52 patients who qualified and participated, their less than 30-day readmission rate went down to 7%. So quite dramatic. This program now, they have about 720 sets of equipment. So the benefits, meets the triple aim, but improves the patient experience. Patients love, the majority of the patients love the technology and don't want it to leave. They get a lot of social contact, which also helps in staying healthy. Improves the health of populations, as well as reduces the per capita cost of health care, which we've just talked about. So what is the primary barrier? Well, it's the same primary barrier that's been facing us for the past 20 years, and that's no Medicare reimbursement. So usually the conversation would end right there. There's no Medicare reimbursement. Yes, there's a lot of bipartisan bills that are trying to get through, but we have another way to be able to help offset the cost of remote patient monitoring. That's implementing CMS's chronic care management program. This program is a way for primary care provider practices, hospitals who own physicians, health systems who own physicians, to be able to increase their revenue and offset the cost of remote patient monitoring. So what is the chronic care management? The CPT code is 99490, and the criteria for this are Medicare patients that have 2 or more chronic conditions that are expected to last at least 12 months or until death. Well, that's a lot of people over the age of 65. The person has to be at significant risk of death, acute exacerbation, or functional decline. And all you have to do is provide 20 minutes of non-face-to-face care coordination. So the primary care provider, the nurse practitioner, the PA, they don't have to provide these services. It can be provided by someone else in their office or outsourced, and I'll talk about that more in a minute. So the national reimbursement is $42.60 per Medicare patient per month. And then I always recommend to start with a patient who has secondary insurance, because there is a 20% copay. So you're looking at a rate of about $50 per patient per month. You're thinking, a lot of work for $50 per patient per month, but hold on a little bit. We're going to do some math in it a little bit to help you realize the significance. So when this law was passed and then implemented January 2016, there were a lot of restrictions. And a lot of those restrictions now have been lifted. Previous to January, you had to have a formal signed consent with the patient in the office. That has been lifted. You can have a phone consent or a signed consent. So that allows you to be able to reach out via phone and enroll patients. And you didn't have to educate during a face-to-face visit as long as the patient had been seen 12 months before. Before, there were 3 types of visits that you had to come into the clinic for in order to be qualified. Those things have been lightened. They also now, you can outsource these services. So if you're an organization and you want to increase the revenue, but you don't have the staff to do this, you actually can outsource this to be done. And they've added 2 new CPT codes. The first one is CPT code 99487. So the patient is Medicare 2 or more chronic conditions, and they met 20 minutes of care coordination with me. They could bill the $42, what did I do? Anyway, the $42.60, whatever that was. But if I'm a complicated patient and I receive 60 minutes of care coordination, you can bill for $89.25, which brings your payment up to $107 per patient per month. So 20 minutes, you get 42. If you do 60 minutes, you get 89.25 plus the co-insurance. Then the newest code also is 99489, and that says, okay, if you do the 60 minutes, then every time you do 30 more minutes that month, you get $44.79. So what they're trying to do is to incentivize physicians to start implementing this program to be able to better provide coordination with patients. Now, why has there been a high uptake in chronic care management? Mainly, practices lack infrastructure. A lot of current EHRs don't meet the CMS requirements. CMS requires that there's a comprehensive patient care plan, not a physician plan of care, but a patient care plan. They require an electronic timer so you can document, electronically stamp exactly what was done and how long it took, as well as Medicare audit report. So those are some things that there's several companies that have created software that meet these requirements. They fear the burden of documentation and the fear of penalties. And honestly, providers really didn't understand the potential revenue. So those are the main reasons there's been a low uptake in CCM. Providers eligible to bill: physicians, advanced practice nurses, physician assistants, and clinical nurse specialists. They included midwives, but not many Medicare patients are having babies, so I didn't add that onto the list. With the services, you conduct an annual health assessment over the phone. Remember, the provider's not providing the service. Then a care plan has to be created for that patient, and the patient has to be given a copy of that plan, whether it's written or electronic, so that the patient has their plan of care, meaning I want to lower my blood pressure, I want to increase walking by 10 minutes, blah, blah, blah. And that way the nurse has it, or whoever's doing these services, and the patient has it. And as you do these 20 minutes of call, you can update the progress of that patient in meeting their goals, or lack thereof. So here are the different things that you can do with a patient for that 20 minutes. You can review their medication. If they're out of their meds, you can call the pharmacy for them. And any amount of time you're on the phone calling on behalf of the patient counts. Conduct health assessment surveys. Review and update their care plan. Make sure that they've gotten preventative services, such as someone over 65, have you gotten your flu shot? Have you gotten your pneumonia vaccination? All of those things that we want people to do preventatively. Monitor their condition. How are you feeling? Looking at mental, social, psychosocial, physical, environmental. Provide patient education and address any of their questions. And then a big one is helping to identify and arrange for needed community resources. So if we have a patient that you're working with and they don't have transportation to get to an appointment, okay, what can we do? What resources can we provide for this person to be able to make their appointment? And then to increase the communication between providers. See what my time is, okay. Projected reimbursement. On a national average, I'm going to say this slow, on a national average, a primary care provider averages a panel of 2,500 patients. Let's say very conservatively that only 16% of those 2,500 patients are Medicare. And then let's say that only 69% of those Medicare patients will have 2 or more chronic conditions. So I would think very, very conservative projection. That would allow each provider to have a panel of 200 patients on chronic care management. 200 patients times $42.60 in an annual revenue, that's $102,000 in annual revenue for providing 20 minutes of non-face-to-face care coordination for their patients. They're already doing it. They're just not getting paid for it. Somebody is in that office answering the phone and doing this stuff. On a copay revenue, you're looking at an additional $20,000, about $20,500 in additional revenue. For a total of just one physician, one NP, nurse practitioner, they're going to bring in an additional about $122,728 in extra revenue per 200 patients. So if you do the math, and I'll share the math with our customer, Appalachian Regional Health, their year one, they're targeted, we have them pull a report of all their Medicare patients. And then we had them pull a report of all of their Medicare patients who had secondary insurance so that copay wasn't a barrier. They identified 1,020 Medicare patients, which was less than 25% of their total Medicare patients with secondary insurance. Their first year annual revenue, $227,327. Once they get to 1,020 patients, on an annual basis, that revenue is over $700,000. So there really is a way to be able to generate pretty significant revenue. Now you're saying, well, what has this got to do with remote patient monitoring? Well, Can remote patient monitoring be included in the 20 minutes? Yes, it can. However, it cannot be the only thing that you're doing. So let me give you an example. If I was at hospital discharge, given remote monitoring equipment, and then I went to my primary care provider, and they enrolled me in chronic care management. Once 20 minutes is met, whether it's providing remote patient monitoring services or chronic care management services, you can drop that bill. However, if you have a remote patient monitoring only patient, not enrolled in chronic care management, you cannot be reimbursed. So, having said that, here's a pretty good model to increase revenue. Identify patients in the hospital for remote patient monitoring. Make sure before discharge they're scheduled for an evaluation and management or an annual wellness visit within 7 days of discharge. A patient who is seen by a provider within 7 days of hospital discharge, their reimbursement is like $183. Between 7, 8, and 14 days, that amount decreases like $120. If it's over 14 days, that reimbursement decreases between $60 and $70. So from a revenue stream, it'll be very important to sign that patient up for clinic visit within 7 days, and while they're in that clinic, enroll them in chronic care management. Then you can provide remote patient monitoring services. Once you meet 20 minutes, you can bill, or wait till you get to the 60 minutes and you can bill that, and it's a way to be able to capitalize on these new CPT codes. And then once remote patient monitoring ends, you can just continue with chronic care management. Benefits provider increased revenue. It serves as a bridge from fee-for-service to value-based, and it increases patient care coordination. And I'm going to wrap it up after this slide so we can take questions. One of the things, I've participated this year remotely at Matrix Summit. I was at HIMSS, as well as American Telemedicine Association this year. And one thing that's really happening in the industry is organizations are wanting to be able to provide multiple services using multiple vendors' devices. And the only way to do that is for either the development of software that can do all of these things, which has been done, and or the willingness of the vendors and electronic health records working together to make this happen. I think of a national scale, it's a huge issue of not having a single sign-on process, and you have to integrate in with electronic health records, or you're not going to be able to scale and move the way you want to. So I really encourage you to be looking at software platforms that can allow you to work with any vendor that you want to based on the patient population and the needs. And now we'll stop and take questions. I know I packed a lot in a very short time. Do we have any questions, Anita?
Yes, would you like me to read them off?
Sure.
Okay.
Or can I see them somewhere?
Yeah, go under Q&A. You can see them in there.
Oh, okay.
Okay.
I got it.
I answered some that I could, but most of them are for you.
Okay. CJ King asked, I'm curious to hear about reimbursement for these services from medical insurance. What is the situation in your state? Are services provided by an RN reimbursable? If you're talking about chronic care management, there are a lot of payers who are now reimbursing for chronic care management. I know Blue Cross Blue Shield of North Carolina just started that. From a remote patient monitoring perspective, there have been some medical insurances that do reimburse for that, but the number that do are far outweighed, unfortunately, by the numbers that don't. The services provided by the RN are not reimbursable at this time. Stanley, the patient's medications are controlling your data. How well do you know that the patient is taking their medication? That's a good question. So one of the ways we track that is when we do the initial installation and that first meeting with the patient is to review their medications, and part of meta reconciliation is how many meds do you currently have, as well as when are your medications due to be renewed. So that's one way, by knowing that you can track it. For patients that we're really not sure whether they're taking their medications or not, then we're working with inexpensive medication reminders, as well as other medication adherence devices. The thing about it, even with all of these devices, it can tell you when you need to take your medicine. You can press a button saying that you took it, but there's no way to prevent people from lying to it. Is it important the remote monitoring devices have FDA approval as a yes? Absolutely. What is the name of the TV product? The name of that is EOCene, EOCENE. Is there any movements towards CMS reimbursing for devices enabling chronic care management? That's a good question, and I don't know the answer to that. Right now, all of the CMS reimbursement for chronic care management is for live, non-face-to-face. So having devices or apps, other means of being able to collect data like a health assessment electronically has not been approved yet. But if it's only been here 2 years, I'm real pleased after the first year they've made pretty significant changes. We have asked for the elimination of the copay, not we, I mean as me, but the industry, because that is a great barrier. That's why I recommend for organizations to start with patients who have Medicare and secondary insurance, because it eliminates that barrier. And then you have time to create a story to tell with your patients. What challenges do you have with getting patients to agree to CCM when they have out-of-pocket expenses? That's a really good question. At Appalachian Regional Health, for an example, they currently have like 500 and some patients on, and they've had over the past year, about 52 patients have dropped off because of that, and they simply don't have the money. And so that's why all of us that want to provide CCM, we really need to keep giving Medicare feedback that the people, probably the folks in the greatest need, who are living in poverty and don't have access, are the patients that don't have secondary insurance. So it makes it, it creates a barrier that's limiting us to be able to reach, I would think, folks who really need this.
Well, thank you very much, Bonnie. And
you're welcome.
I also wanted to bring to everyone's attention that after this, we're going to have a survey. So I would appreciate everybody filling that out. And if you have additional questions, anybody else, additional questions, or we all set?
Okay, I'm putting up the next slide for you, Kathy.
All right.
I mean, Anita, excuse me. And there's my contact information if anybody would like to contact me. I would welcome it. And Anita?
We also want to welcome you to continue with the webinar series. It's the third Thursday of every month. And the next one will be June 15th, as it says here. And we invite you to join. Here's the survey.